My name is Marcus Chen, and I've been a pharmacy technician at Johns Hopkins Hospital in Baltimore for 14 years. I work in the inpatient pharmacy, filling prescriptions for hospitalized patients, verifying medications, ensuring accurate dosing and drug interactions. I'm not a pharmacist. I don't have the authority to make clinical decisions, but I'm the person who physically prepares the medications that keep patients alive. I've filled over 200,000 prescriptions in my career. I know drug names, dosages, contraindications. I can spot errors before they reach patients. I understand the critical role of medication in medical care. But on October 3rd, 2023, I started seeing prescription labels change after I'd already filled them. The label would say atorvastatin 20 milliliters for hyperlipidemia when I filled it. But minutes later, when I double-checked, it would read warfarin 5 milliliters for atrial fibrillation. The patient's diagnosis would change. The disease would be different. The future would rewrite itself on prescription labels I'd already processed. I was filling prescriptions for diseases that didn't exist yet but would develop within days. And if I filled what the changed label showed instead of what was originally ordered, I could prevent diseases before they manifested. But I'd also be committing medication errors that could get me arrested. Johns Hopkins Hospital is one of the most prestigious medical institutions in the world. Our pharmacy operates with military precision, computerized order entry, multiple verification steps, barcode scanning at every stage. Medication errors are rare and taken extremely seriously. A single wrong drug or wrong dose can kill someone. I grew up in Rockville, Maryland, in a Chinese-American family. My parents owned a small restaurant, worked 18-hour days, expected me to become a doctor or engineer. I didn't have the grades for medical school, but I found pharmacy technology, a way to work in healthcare without years of additional education. I got certified, started at Hopkins in 2009, and built a career on accuracy and reliability. 14 years later, I'm senior pharmacy tech in the inpatient department. I train new techs, handle complex medication orders, work closely with pharmacists on difficult cases. I'm known for catching errors, for double-checking everything, for being meticulous, maybe too meticulous. October 3rd, 2023 started as an ordinary Tuesday. I arrived at the pharmacy at 7 a.m. for the day shift. The morning was busy. Post-surgical patients needing pain medication, antibiotic orders for infections, cardiac drugs for ICU patients. Standard hospital pharmacy work. At 9:17 a.m., I filled a prescription for a patient in room 3142. Elizabeth Morrison, 62 years old, admitted with pneumonia. The order was for levofloxacin 750 milliliters IV, a standard antibiotic for bacterial pneumonia. I prepared the medication, labeled it correctly, scanned all barcodes. Everything verified? I placed it in the outgoing medication bin for delivery to the floor. 10 minutes later, I was restocking supplies when I glanced at the bin. The label on Elizabeth Morrison's medication had changed. Where it had said levofloxacin 750 milliliters IV for community-acquired pneumonia, it now read Enoxaparin 40 milliliters SC for pulmonary embolism prophylaxis. I picked up the bag, examined it closely. The label was different. The medication name was different. The diagnosis was different. But I distinctly remembered filling levofloxacin for pneumonia, not enoxaparin for blood clot prevention. I checked the computer order. It still showed levofloxacin for pneumonia. But the physical label on the medication I'd prepared showed enoxaparin for PE prophylaxis. I assumed I'd made an error, grabbed the wrong medication. I pulled the bag from the bin, disposed of it, and filled the order again. Levofloxacin for pneumonia, exactly as ordered. But as I placed the new bag in the bin, I watched the label shimmer and change. The text rearranged itself before my eyes. Levofloxacin became enoxaparin. Pneumonia became pulmonary embolism prophylaxis. The label was changing after I'd filled it, rewriting itself, showing a different medication for a different disease. I stood there staring at the impossible transformation, my hands shaking. This wasn't a mistake. This was something else entirely. I checked Elizabeth Morrison's chart. She'd been admitted 48 hours ago with bacterial pneumonia, confirmed by chest x-ray and labs. No mention of blood clots, no indication for anticoagulation, no risk factors for pulmonary embolism. But the changed label showed Enoxaparin, a blood thinner used to prevent clots. Why would the label change to show medication for a condition she didn't have? I decided to document what I'd seen and move on. Probably a computer glitch, a label printing error, something explainable. I filled the levofloxacin as originally ordered and sent it to the floor. 3 days later, on October 6th, Elizabeth Morrison developed a pulmonary embolism, a blood clot in her lungs, an emergency that could have been prevented with prophylactic anticoagulation. With enoxaparin, the exact medication the changed label had shown. I pulled up the incident report. The medical team noted that Morrison had no identified risk factors for PE, so prophylactic anticoagulation hadn't been ordered. It was described as an unexpected complication, but I'd seen it coming. The label had changed to show the medication she needed for a condition she would develop 3 days later. On October 9th, it happened again. Patient David Foster, 55, post-operative day 1 after hip replacement. His order was for morphine 4 mg IV PRN for pain. I filled the morphine, labeled it, scanned it. Standard post-op pain management. When I placed it in the outgoing bin, the label changed. Morphine became naloxone. Post-operative pain became opioid overdose reversal. Naloxone is the medication you give when someone has taken too much opioid and stops breathing. It reverses the overdose, saves lives. But David Foster wasn't overdosing. He'd just had surgery. He needed pain control. I checked his chart. No signs of opioid sensitivity, no history of adverse reactions, normal dose prescribed. There was no reason to give him naloxone instead of morphine. But the changed label insisted naloxone 0.4 mg IV for opioid overdose. I filled the morphine as ordered. The label kept changing to show naloxone. That evening, David Foster received his morphine dose on the surgical floor. At 11:47 p.m., he had a severe reaction, respiratory depression, oxygen levels dropping, barely responsive. The nursing team had to give him naloxone to reverse the opioid effect and restore his breathing. If they'd had naloxone immediately available at his bedside, the response would have been faster. If I'd filled what the changed label showed, instead of what was ordered, the medication needed for his emergency would have already been there. The labels were showing me future medical needs. Medications for conditions that would develop days after the original prescription was filled. Over the next 2 weeks, I documented every instance of label changes. They happened randomly, unpredictably, maybe 2 or 3 per day out of hundreds of prescriptions I filled. A prescription for insulin would change to show dextrose for hypoglycemia. An order for lisinopril for blood pressure would change to show epinephrine for anaphylaxis. A prescription for omeprazole for acid reflux would change to show pantoprazole for stress ulcer. In every case, within days, the patient would develop the condition shown on the changed label. The medication I'd been told to fill wasn't what they would actually need. The labels were showing me the future, and the future was always different from the present. On October 24th, I filled a prescription that forced me to make a choice. Patient: Emily Rodriguez, 8 years old, admitted with asthma exacerbation. Order: albuterol nebulizer 2.5 mg for bronchospasm. I filled the albuterol, labeled it correctly. Standard asthma treatment for a child in respiratory distress. The label changed. Albuterol became epinephrine. Bronchospasm became anaphylaxis. Epinephrine is for severe allergic reactions, life-threatening emergencies. Emily Rodriguez had asthma, not anaphylaxis. But the changed label showed that within days, she would need epinephrine for an allergic emergency. I stared at that label for a long time. If I sent the albuterol as ordered, Emily would get treatment for her current asthma. But if she developed anaphylaxis later, the medication she'd need wouldn't be readily available. If I filled the epinephrine instead, what the changed label showed, she'd have life-saving medication on hand when she needed it. But I'd also be dispensing the wrong drug for her current condition, violating every protocol, committing a medication error that could get me fired or arrested. I made a decision. I filled both, albuterol as ordered for her current asthma, and epinephrine, unauthorized, not ordered by any physician, labeled for emergency use only, anaphylaxis, and included it in her medication delivery with a note to the floor nurse. Patient may be at risk for allergic reaction. Emergency epinephrine provided as precaution. It was a medication error. I'd dispensed a drug without a physician order. If discovered, I'd lose my certification, my job, possibly face criminal charges. On October 27th, 3 days later, Emily Rodriguez had a severe allergic reaction to an antibiotic. Anaphylaxis, rapidly progressing, life-threatening. The floor nurse grabbed the epinephrine I'd sent, administered it immediately, saved Emily's life. The medical team was baffled. Why had pharmacy sent epinephrine for an asthma patient? Why was it available at her bedside? Who had ordered it? I received a summons to meet with Dr. Patricia Hall, the director of pharmacy. Marcus, there's a medication discrepancy involving Emily Rodriguez. Epinephrine was dispensed and administered, but there's no physician order in the system. Did you send that medication? Yes, I did. On whose authority? Mine. I had a strong concern about allergic reaction risk. You're not authorized to make clinical decisions. You're a technician, not a pharmacist or physician. You can't dispense medications without orders, but it saved her life. She would have died if that epinephrine wasn't immediately available. That's not the point. You violated fundamental protocols. If you had concerns about allergy risk, you should have contacted the prescribing physician or the clinical pharmacist. You don't make those calls yourself. Would anyone have listened? Would anyone have ordered prophylactic epinephrine based on a pharmacy tech's hunch? Dr. Hall was quiet for a moment. No, probably not. But that doesn't justify what you did. I'm placing you on administrative review pending investigation. I was suspended on October 30th, 2023. 14 years of excellent service ended because I'd filled a future prescription instead of a present one. During my suspension, I obsessed over the label changes. I documented every instance I'd observed, every prediction that came true. 23 prescriptions with changed labels, 23 accurate predictions of future medical conditions. The pattern was undeniable. The labels were showing me temporal displacement, medications needed in the future appearing on prescriptions filled in the present. If I filled what the labels showed me instead of what was ordered, I'd be preventing complications, saving lives, giving patients medication before they knew they needed it. But I'd also be committing medication errors, practicing medicine without a license, acting outside my scope of practice. On November 8th, I was called back to Johns Hopkins for a meeting with Dr. Hall, the Chief of Staff, Dr. Raymond Park, and a hospital attorney. Marcus, we've completed our investigation. Your dispensing of unauthorized epinephrine to Emily Rodriguez constitutes a serious medication error. However, given that it resulted in a positive patient outcome and you have no prior disciplinary history, we're prepared to offer you a choice. What choice? You can resign voluntarily, we'll provide a neutral reference, and there will be no report to the Board of Pharmacy. Or you can face formal disciplinary proceedings, which will likely result in termination and a board complaint that could cost you your certification. So either I quit or you fire me and destroy my career. We're giving you the option to leave with dignity. I looked at Dr. Hall. What about the next time? What about the patient whose label changes and no one notices because I'm not there? There won't be a next time. Label changes don't happen, Marcus. You misread labels or experienced some kind of perceptual error. We've examined the pharmacy's label printing system. There are no glitches, no errors that would cause labels to display incorrect information. Then how did I know Emily Rodriguez would need epinephrine 3 days before she had anaphylaxis? The attorney spoke up. Mr. Chen, if you continue to claim you can predict future medical conditions through supernatural means, that will be included in our report to the Board of Pharmacy as evidence of impaired judgment. I understood. Either accept that I'd made lucky guesses or be declared mentally unstable. On November 10th, 2023, I resigned from Johns Hopkins Hospital. For weeks, I tried to understand what had happened. I researched temporal phenomena, precognitive experiences, reality displacement. I found nothing that explained seeing future prescriptions on present-day labels, unless the labels weren't changing, unless I was seeing two temporal layers simultaneously, the present prescription and the future need, overlapping in my perception. In December, I got a job at a retail pharmacy in suburban Baltimore. Lower pay, less prestige, but they needed techs and didn't dig too deep into why I'd left Hopkins. On my second day, I filled a prescription for a customer. Susan Park, 45, atorvastatin 20 ml for high cholesterol. Standard statin medication. The label changed. Atorvastatin became clopidogrel. High cholesterol became acute coronary syndrome. I stared at that label, knowing what it meant. Within days, Susan Park would have a heart attack, and clopidogrel, a blood thinner used after cardiac events, was what she'd need. If I filled the clopidogrel instead of the atorvastatin, I'd be giving her medication that could prevent the heart attack from being fatal. But I'd also be committing fraud, dispensing medication without authorization, practicing medicine illegally. I filled the atorvastatin as prescribed. I couldn't risk my certification again. 4 days later, I saw Susan Park's name in the local news. She'd had a heart attack, was hospitalized, survived, but with heart damage. I could have prevented that, or at least minimized it, if I'd filled what the label showed me. That night, I made a decision. I started a private log. Every prescription where the label changed, I documented it. Patient name, original prescription, changed prescription, date. I noted when the predicted condition developed. I couldn't fill the future prescriptions without getting arrested, but I could warn people. On December 18th, a prescription came through for Michael Torres, 52, metformin for diabetes. The label changed to show insulin for diabetic ketoacidosis, a life-threatening complication. I filled the metformin as ordered, but I also called the customer. Mr. Torres, this is Marcus from the pharmacy. I'm calling about your diabetes medication. I want to make sure you're monitoring your blood sugar very closely over the next few days. If you notice any unusual symptoms, excessive thirst, confusion, rapid breathing, please go to the emergency room immediately. Is something wrong with my medication? No, the medication is correct. I just have a concern about your diabetes management. Please be extra vigilant. 3 days later, Michael Torres went to the ER with early diabetic ketoacidosis. Because I'd warned him to watch for symptoms, he caught it early. He received treatment before it became critical. I'd found a middle path. I couldn't fill the future prescriptions, but I could use the information to give warnings, encourage vigilance, potentially save lives without breaking laws. On January 5th, 2024, a prescription came through that made me question everything. Patient: Lily Zhang, 6 years old. Prescription: amoxicillin, 400 milliliters suspension for ear infection. Standard antibiotic for a child with otitis media. The label changed. Amoxicillin became glucagon. Ear infection became severe hypoglycemia. Glucagon is emergency medication for dangerously low blood sugar. Why would a 6-year-old with an ear infection need emergency glucose treatment? I checked the prescription notes. No mention of diabetes. Just a simple ear infection. But the changed label was insistent. This child would need glucagon for hypoglycemia. I called the customer, Lily's mother, Jennifer Zhang. Mrs. Zhang, this is Marcus from the pharmacy. I'm filling Lily's antibiotic for her ear infection. I wanted to ask, does Lily have any history of blood sugar problems? Diabetes? Hypoglycemia? No, nothing like that. Why do you ask? Just being thorough. Sometimes antibiotics can affect blood sugar in rare cases. If you notice any unusual symptoms, shakiness, confusion, extreme tiredness, please contact her doctor immediately. Okay, thank you. But she's never had blood sugar issues. I filled the amoxicillin as prescribed, but I couldn't shake the feeling that I was missing something critical. 2 days later, Lily Zhang was rushed to the ER with severe hypoglycemia. The antibiotic had triggered a rare reaction in her body, causing dangerously low blood sugar. She went into a coma. The ER team gave her glucagon, the exact medication the changed label had shown, and she recovered. But if I dispensed glucagon when I filled her prescription, if her mother had it available at home when symptoms started, Lily wouldn't have coded. I'd seen it coming. I'd warned the mother. But I hadn't been specific enough, urgent enough, and I couldn't have given her glucagon without a prescription. That would be dispensing controlled medication to a child without authorization. A 6-year-old girl went into a coma because I couldn't fill the prescription the changed label showed me. On January 12th, I requested a meeting with the pharmacy manager, David Kim. David, I need to discuss something unusual I've been experiencing. What's that? I've been seeing prescription labels change after I fill them. They show different medications, different diagnoses, and the changed labels always predict future medical needs accurately. David looked at me like I was insane. Labels don't change, Marcus. If you're seeing that, you might need to see a doctor. I've documented 29 cases. Everyone came true. Patients developed the conditions shown on the changed labels within days. That's confirmation bias. You're remembering hits and forgetting misses. There are no misses. Every changed label predicts accurately. Then you're reading the labels wrong, or experiencing some kind of neurological issue. Either way, if you're not confident in your ability to accurately read prescription labels, you can't work in pharmacy. I was placed on medical leave on January 15th, 2024, required to undergo neurological and psychiatric evaluation before returning to work. The evaluations found nothing wrong. No vision problems, no cognitive issues, no mental illness. But they also couldn't explain what I was experiencing. On February 1st, I was terminated from the retail pharmacy. Not a good fit, they said. The real reason, they couldn't risk employing someone who claimed to see future prescriptions. I'm 38 years old. I've worked in pharmacy for 14 years. I've filled over 200,000 prescriptions, and I've developed an ability that makes me invaluable. I can see what patients will need before they need it. And unemployable, because using that ability means breaking every rule of pharmacy practice. I can't work in pharmacy anymore. No one will hire someone who's been terminated from 2 positions for medication discrepancies and perceptual issues. But I still see the label changes. When I pick up my own prescriptions, I see them transform. When friends ask me to check their medications, I watch the labels rewrite themselves. I know what people will need before they know it themselves. I can see medical futures written on prescription labels. And I can't do anything with that knowledge without destroying my life, unless I find another way. I've started a blog, anonymous, untraceable. I post warnings about medication risks, about watching for specific symptoms, about being prepared for medical emergencies. I don't claim supernatural ability. I just share pharmacy tech insights about potential complications. When I see a label change, I post about that drug class, those symptoms, that condition. I reach people I can't call directly. I give warnings I can't give in person. It's not enough. It doesn't save everyone, but it's something. Last week I received an email from someone who'd read my blog. They'd been taking a medication I'd warned about. They'd watched for the symptoms I'd described. When they developed the complication I'd predicted, they caught it early. They said I'd saved their life. I'll never work in a hospital pharmacy again. I'll never have the authority to dispense medications, to make clinical decisions, to use my ability where it could do the most good. But I see the future written on prescription labels. I see temporal displacement of medical need. I see medications arriving before diagnoses, and I'll find ways to share what I see, even if no one knows it's me, even if I can never prove how I know, because someone has to bridge the gap between prescribing and needing, between diagnosis and complication, between present treatment and future emergency. Someone has to see the prescriptions that haven't been written yet, and that someone is me.